Thank you ever so much for coming tonight. I think lymphoma is an absolutely fascinating disease and I really appreciate your interest. Let's look at some of my cases first. This is an elderly cat presented for visual issues. What's wrong with his eye? Detached retina, absolutely. And what's your top differential in an elderly cat? Absolutely. And this is a middle-aged German Shepherd with a non-weight bearing lameness and a hard, very osteolytic swelling in the right scapula. What's your top differential there? Possibly. Osteosarcoma, someone said. This is a 10-year-old miniature Schnauzer with a week's history of tenesmus, hematochezia, and an ugly mass in the mid-rectum. When we imaged the chest, there were nodules like this, and like that, and like that, and like this. What's your top differential there?
Carcinoma.
Yeah, metastatic carcinoma is not a bad call in this. And finally, we've got Honey, a 9-year-old golden retriever. And over the course of about 8 days, one by one, each of Honey's nipples went black. And then it dropped off. And that's both on the right side and on the left side. What's your top differential there? I don't know either. But the key point is that these 4 animals all had lymphoma. And that brings me to point 1. You can put lymphoma on the differential list for pretty much any lesion, but I'd recommend prioritising it higher on the differential list when the tissue involved is enlarged, when the tissue has a lymphoid function, for example, third eyelid, liver, spleen, or if the patient is a cat. Okay? Moving on. Lymphoma looks like this. It's a load of lymphocytes, and what you're looking at is a visible clone of cells. They may be small, medium or large size. They may or they may not have morphologic abnormalities, but the key point is very simple. They all look the same. The differential diagnosis is an immune-stimulated lymph node, and of course you've got all sizes and shapes of cells there, with a predominance of the small, unstimulated lymphocytes. You've also got all morphologies here. You've got the dark, dense staining nuclei are the small ones, and we've got the open, pale nuclei of the large ones. That's because there's lots of chromatin unwound, lots of genes being transcribed. You've got some with a pale area in the cytoplasm, and these are probably B cells with immunoglobulin. And you've got some with this sort of tear-shaped morphology here, which are probably the T cells. And this makes sense because an immune response will be to lots of antigens at once. And you've got lots of different types of lymphocytes responding to different antigens in different ways. Lymphoma describes the situation when one of these lymphocytes, and it can be any one of these, will start proliferating to a malignant excess and often efface everything else that's going on. Okay? So over to you now. What's this? Is this reactive or is this lymphoma? Lymphoma. Absolutely, I agree. I think they all look the same. In fact, there's these ones here are the small ones. We've got a vast predominance of larger cells, which supports lymphoma. They also have the same morphology, often with a kind of slightly cleaved nucleus there, so that's quite a clear-cut case. And what's this?
Reactive.
Absolutely. And what's this? Absolutely, I agree. And in fact, this one you can go further than saying the cells look all the same, because we've got things like this, mitoses. I was certainly taught at school, and I hope you were too, that mitosis involves a nucleus dividing into 2. I don't think there's any textbook of biology anywhere in the world that talks about a nucleus dividing the nuclear material irregularly into 3. What's going on here? This highly abnormal mitosis on its own is a very, very strong feature of malignancy. Now, I'm not saying we should replace clinical pathologists here, because quite often the diagnosis is not so straightforward. But even when the diagnosis is fairly easy, we still want someone with the qualifications of a board-certified pathologist signing off on things before we start talking about guarded prognoses or cytotoxic drugs. Also, we want to take advantage of the expertise these guys have, and we want more information than just, is it lymphoma, yes or no. But I can also give you 3 reasons why I think we should look at our own cytology in-house. And the first one is this. What's this? You can see kind of, it's like whorls of cells stuck together with a little hole in the middle. And the way the cells line up like this suggests you've got a very proteinaceous background here, as if there's a very viscous secretion. And this is a perfectly normal salivary gland, submitted to the lab with a form that said mandibular lymph node, and signed off by a professor of internal medicine. So, the main reason why we look at our own cytology is that we don't want to look like a muppet. The second one, though, is, I think we all know, some dogs with lymphoma can present desperately ill, and even more cats, actually. And these ones that present ill are going to make a beeline for 4:30 on a Friday afternoon before a bank holiday weekend. So with a lot of these guys, it really does help you to make a strong working diagnosis, and we can start treatment going as soon as the animal needs it. And my third point is more of a romantic one. I think it's quite special the way you can look down a microscope and you can see the disease in action. That really helps you to understand the biology of what's going on. So I'm going to ask you to consider a question now. We all get these. At some point we'll submit cytology to the lab and the pathologist says, this is suggestive of lymphoma, but I can't call it here. We're going to need other tests. What test would you like to do? Just have a think a minute. I'm going to introduce to you 3 tests here, and all of these can be used to rule in or rule out a diagnosis of lymphoma. But actually, each one of these will provide you with a huge packet of information. And I maintain that we should choose the particular package of information that suits our case and our budget and our owner best, rather than the one that the clinical pathologist might recommend to solve a very specific question. So I'm going to discuss these in a little bit of detail now, and I'll return to them periodically through the talk to put them more in context. First is histopathology. We all know what it is, and I'm not going to labour the point, but histopathology is the High Court of diagnosis. And in answering the question, is this lymphoma? Well, histo wins. What I would say, though, is when you're doing histopathology on a lymph node, please take the lymph node out where possible. Please don't mess around with true cut biopsies. And the reason is that, as you can see here, the lymph node has a very, very definite architecture. And to make a call on what's going on the lymph node, the pathologist needs at least 3 things. They need to see the germinal centres, where the B cells are, the paracortex, where the T cells are, and they need to see how this relates to the capsule. Now I can tell you, if you take a true cut biopsy, you will never get a good bite of the capsule. And you could possibly do something like this. We have missed the germinal centre. We could have missed a lot of B-cell lymphomas this way. But that's okay. We re-angle the implement and we take another biopsy and we miss again. We re-angle and we miss again. And it's quite possible to get non-diagnostic true cut biopsies by just getting poorly representative samples. The PAR test is an extremely clever DNA test, and it relies on a couple of unique features about the biology of a lymphocyte. Every cell in your body should have identical DNA. Okay? That is apart from the lymphocytes, where each lymphocyte has a very small piece of DNA that is specific just to that lymphocyte and not shared with any other lymphocytes or any other cells. This bit of DNA, of course, codes for the lymphocyte receptor. And the specificity of that receptor underpins the specificity of the acquired immune response, and it's probably the reason why we're all here today. Now, when a lymphocyte encounters the antigen to which it is specific, it will clone itself to form an army to address this particular antigen. And that clone of lymphocytes that's formed can be detected with a PCR test. Okay? Now, when you have a normal, benign immune response, just as your average virus, bacterium, parasite will have lots of antigens, you'll have lots of clones of lymphocytes responding to lots of antigens. And if you run a PAR test, you'll pick up lots of clones and give you a polyclonal response. If you have lymphoma, you'll have one clone. It will have originated from just one lymphocyte, and you'll have a monoclonal response. And this way then, if you have a load of lymphocytes and you're wondering, is it lymphoma or is it reactive, PAR is a very good way of saying yes or no. PAR is also attractive because it's a PCR test. And what do we all know about PCR? Well, it's used in forensic science. And if you watch CSI Miami or other shows, you will learn that you can do a PCR test reliably on a drop of blood on a shirt that's been 30 years old. So you can certainly do the PAR test on the stain slides that are already with the pathologist, and it makes it quite convenient like that. In fact, due to the technicalities of running the PAR test, the only thing you can't really do PAR on is formalin fixed tissue. There's some significant drawbacks though, and that most of the commercially available PAR tests are kicking around the 70% sensitivity mark. Now, if you guys are a little bit rusty on what that means in real terms, if a test is 70% sensitive, then you need to run it 3 times on dogs with lymphoma. It's going to get it wrong once. Okay? And given how common lymphoma is, it's not going to be long before you get burned by this test if you're using it routinely. So that is a particularly significant drawback. The sensitivity in cats is lower than dogs, but I will say that both in cats and dogs the sensitivity is slowly being improved as we evaluate the test more and more. If you get a positive on the PAR, you can usually trust it. That usually means you've got lymphoma, but there are a few situations where you get false positives. And the first is with Ehrlichia. You get a clonal proliferation of B lymphocytes. And Borrelia, Lyme disease, you get a clonal proliferation of T lymphocytes. And the other place where I've encountered false positives on this is where the test is being run in a situation where it's not really been evaluated. For example, in a cat with pyothorax and large lymph nodes in the chest. I've seen people asking a very, very good question: is this a pyothorax that has somehow been caused by neoplastic process in the chest? And it would be great if we could do a test on the pyothorax fluid to rule that in, rule that out. Well, actually, in a pyothorax, most of the action is with neutrophils and monocytes. It's mostly the innate immune system. There are lymphocytes there, but they'll be few and far between, and they won't be doing much. And the chances are you may only detect one clone of lymphocytes there. So we'll caution you to have seen people get false positives on the PAR, just using it in a situation of acute inflammation where lymphocytes are not a big feature. And the other place where people can go wrong is with CSF, where there's just not many lymphocytes anyway. And lastly, we'll talk about flow cytometry, which is another modern, really, really clever test. And flow works by running cells in single file past a laser and then measuring the fluorescence and the dispersion of the laser light there. Normally, though, you'd attach a coloured antibody to the cells before they go past the laser, and that antibody is specific for the type of cell. So here we've got a plot of flow cytometry on blood. And you can see that the cells with a blue lymphocyte marker are kind of this big and this complex. And the cells with a yellow neutrophil marker are kind of this big and that complex. And you can see right away then that if suddenly our cells with a lymphocyte marker are plotting up here or over here, we have got an extremely abnormal population of lymphocytes in circulation. But actually, that's not the biggest advantage of flow. The biggest advantage is that you can attach lots and lots of coloured antibodies to assess the cells for expression of lots and lots of different antigens. And that is an immensely powerful thing to do. I intend to prove that to you because I can show you the alternative to flow, immunocytochemistry or immunohistochemistry. This is where you apply your coloured antibody and you visually look down the microscope and see if the cells are expressing it. The cells here that don't express it are blue, and those who express the antigen in question are brown. And if they express the antigen a little bit, it's light brown. If they express it a lot, it's dark brown. If you want to assess more than one antigen here, you're going to have to use two colours, aren't you? And can we really reliably say that we'll be able to predict every cell that has the two colours on it? Because it doesn't take long to see that if you put another colour on this, you just won't see it, or some colours will blend together to make one. So two antibodies will be very hard, and if you're thinking about three, just don't go there. Now, why am I labouring this point? Why is this so important? Just have a think. How many antigens does a cell have? Does anyone want to answer that? How many antigens on a cell? I don't know either, but it's millions. And my point is, you can't identify the type of cell with one antigen alone. And that is the fantastic power of flow cytometry. There are lots and lots of different types of lymphocytes, and that underlies lots and lots of different types of lymphoma. So flow for the first time can identify all these different types of cells. Flow is also an easy test to do, and it's run in the UK, and I suggest at times you give it strong consideration. For flow, we need live cells to get to the lab. So we need to take fine needle aspirates very, very carefully, and several of them, and you need to preserve them in some kind of preservative, and I'd suggest liaising with the lab as to what preservative they would recommend. I send mine to Dick White, the Buttyvilliers there, and she recommends just use of plasma from the same patient. You take a few EDTA tubes, you spin it down, separate the plasma, and you squirt the contents of your needles into the plasma and send it to the lab next day. So that's flow. My point then, these tests will provide a whole load of information each, and they shouldn't be used to answer just one particular thing that the pathologist may suggest. Think of histopathology as asking, what is the diagnosis? Think of PAR as asking, is this lymphoma, yes or no? And think of flow cytometry as asking, what cells are these? If you're wondering how flow cytometry could confirm a diagnosis of lymphoma, then it's all down to proportions. We know roughly what proportions of lymphocytes should be in a lymph node, and similarly in blood. So if we get a significant departure from that, that is highly supportive of a diagnosis of lymphoma. So flow is actually giving you strong support for a diagnosis of lymphoma, but indirectly. So I'm going to spend the rest of the first section now talking about dogs. We've got our diagnosis, it's confirmed, and so we go back and we talk to the owner. And at this point, every single owner in the world will say they don't want their dog to have chemotherapy. That's because chemotherapy makes people really, really ill, and they can't bear the thought of their best friend going through a similar thing. So we're going to need to explain to them that chemotherapy is no more likely to produce side effects than, say, treatment of epilepsy with phenobarb, and no more severe side effects than, say, treatment of heart disease with things like ACE inhibitors, furosemide, digoxin, stuff like that. In the case of lymphoma, at least 90% of dogs will make a very, very marked improvement with therapy, And the prevalence of severe side effects, making a dog poorly for a couple of days, is less than 10%. So you've got an extremely clear risk-benefit ratio there for lymphoma. And after you've addressed that, the owner will ask the most annoying question of all: how long will he live? And as vets, we're pragmatists, aren't we? We tend to think the prognosis is what it is. We've just got to focus on the treatment. And, you know, I subscribe to that view. I think there's a lot of logic there. But really, those dogs who don't do so well on the treatment should be regarded as the ones where we haven't found the right treatment yet. And so the more specific information about these cases, going into things like the Vet Compass database or the insurance company database, then the better for veterinary medicine as a whole. But more fundamentally, in the consult room with you, your dog and your owner, we have compliance issues to think about. If you don't discuss with the owner your projected view on what's going to happen and the course of events with their dog, then they're going to seek that information elsewhere, and you lose a lot of compliance there. The information they seek elsewhere will extend more than just prognosis and probably overlap into treatment and various other things. And of course, this advice may not be from qualified individuals. So from experience, after seeing a lot of lymphoma cases over the last few years particularly, if you address the prognostic issue and give it the time that the owner feels it deserves, then you'll have a much more compliant owner who's much more willing to trust you for the rest of the therapy. So moving forward then, we want to find a prognosis for our dog with lymphoma. The first thing we can do is go to a textbook, and there's lots of prognostic factors listed there, and some of them are very well established and in a lot of detail. But I'm going to present my view now. My first point is look at the information your patient gives you for free. Most cases of lymphoma in dogs are multicentric. That's where the disease is characterised by large peripheral lymph nodes. A minority of the cases, a significant minority, are extranodal, characterised by infiltration of specific areas of the body or organs. But where the boundary can be blurred is that you can get multicentric cases that infiltrate extranodal sites, for example, the alimentary tract, the mediastinum, the skin, the bone marrow, the kidneys. And in a lot of cases of extranodal lymphoma, it also involves several peripheral lymph nodes, and you may well have got the diagnosis from there in the first place. So there are quite a lot of cases of lymphoma where this categorisation, is it nodal, multicentric, or is it extranodal, is quite muddy. For example, if you have a case of a dog with large clementine-sized oranges everywhere, he's got thickened intestines, and he's presented with diarrhoea, are we going to call this an elementary case, or are we going to call it a multicentric case? Actually, I think on that one I'd probably veer towards multicentric. And if we had a dog who had lost lots of weight, had an albumin of 15, fulminant diarrhoea, severely thickened guts, and we had, say, 2 moderately enlarged lymph nodes peripherally, I'd probably call it alimentary. But I hope you can see how it's often a subjective call. Why is all this important? Well, with the extranodal lymphomas, you've got all the prognostic information you need, as long as you recognise the disease properly. Let's take gastrointestinal lymphoma. This is actually dreadful. Half the dogs respond to treatment, and those dogs who respond to treatment enjoy a survival of several months. Okay? Those who don't respond to treatment, the other half, it's usually days to weeks. But don't miss the colorectal lymphomas though. You're not going to see many of these at all. But when you do, they're great. It's like Ned, the miniature schnauzer I showed you at the start. With a very insignificant level of chemo, or what seems insignificant, these guys will live for years. The average survival time is about 5 years, and often they die of other things. So colorectal is a good disease. But the point I'm making here is for these extranodal diseases, there's not much departure from these times here. Hepatosplenic involvement is very, very common with our multicentric cases, and it doesn't affect liver function, doesn't affect prognosis, it's not a problem. But if you see a primary hepatosplenic lymphoma, they'll often be yellow and in a kind of per-acute liver failure. They're often carried in on a stretcher, and the average survival time is less than 1 day. No treatment has been shown to touch them. So certainly with these cases, you don't want to be thinking, oh, it's lymphoma, should do all right with treatment, might survive 2 years. That would be an inappropriate thing there. And lastly, I'll mention cutaneous. Again, it is reasonably predictable. About 8 out of dogs respond to treatment and get a disease-free interval of only a few months. After that, the disease seems to go up a gear, and it's often difficult to treat and difficult to contain the side effects. Often it's a case of just keeping a lid on the clinical signs of disease until a dog's quality of life becomes poor. But again, don't miss the indolent ones, the low-grade, slowly progressive cutaneous lymphomas. They can often stay stable with no treatment for a period of years. You can spot the indolent ones because often it's just a thickening of something, for example gingiva, like that, and not much else. Whereas the higher grade, normal cutaneous lymphomas are often irritating the dog, or if not now, they will do soon, and they're the ones that progress much quicker. But now, because it's more common, we're going to look at the multicentric lymphomas. And forecasting how long these guys are going to live is hard. We've got cases like Loki. We did everything we could for him, and he lived for a few months. And then we got Oscar. We did everything we could for him, and his disease presented almost identically. And he went into remission and stayed there for 9 years and died of something else. And you have everything in between Oscar and Loki. So knowing what's going to go on in a case of multicentric lymphoma is actually really hard. And this brings me on to my 5th point then, that lymphoma is a diverse group of different diseases. Knowing the subtype of disease is not so important for the extranodal ones that are more stereotyped, but for the nodal multicentric lymphomas, I think finding out the subtype of disease is highly important. It helps you choose a treatment and give that all-important prognosis. So that's what we're going to have a quick look at now. These are the types of lymphoma that are available to you. This is the WHO classification of human lymphoma, and it's been shown very, very compellingly to be transferable to dogs. We haven't got time to do all those today, so I'm going to focus on the 6 most common diseases. 3 of these are aggressive, rapidly developing, high-grade lymphomas. When we talk about grade, just to be clear, we're talking about the pathologist's assessment of how aggressive the cancer looks under the microscope. And in forming the grade, they take into account a few things. For example, the rate of cell division, the nuclear morphology, and the overall size of the cells. So these tend to be cancers of intermediate and large lymphocytes. So a lot of clinical pathologists then use the term large cell lymphoma as a shorthand. And the other 3 lymphomas here are indolent, slowly progressive, low-grade lymphomas. They're usually made of small or intermediate-sized cells, and so a lot of our clinical pathologists will call them the small cell lymphomas. Okay? And their survival is very different. If you haven't seen many survival curves before, it's very easy. On the y-axis we have the percentage of animals who are alive, 100% at the top and 0% down here, and on the x-axis we have time. So the groups of dogs who do better have the survival curves nearer the 100% for longer, and those who do worse have the curve nearer the 0% sooner. So we can see then that this blue line here does very well, and that's the T-zone lymphomas. And this brown and this black line here do the worst, and they're the high-grade T-cell lymphomas, the lymphoblastic and the peripheral T-cell. Now this obviously is based on histopathology. It's the standard way of classifying in people, and it does require that you have a histo sample, and that's a bit of a faff, isn't it? But there's some very exciting new research now, and several papers, not just this, that we are finding sets of mutations in lymphoma which have prognostic and therapeutic connotations. This field, called genomics, is the frontier of oncology in people, and it underlies the term you often hear, personalised medicine. You can get identical cancer phenotype created by different sets of mutations, and the cancer phenotype that will look exactly the same patient to patient will fare very differently on treatments and have different prognoses, and that is explained by the underlying mutations. So we can now test for these mutations in lymphoma cases, and companies like this one in the States will be able to receive a stain slide from your path lab and report the results in a few days. So this is a little taste of what's going to happen in the future. The personalisation of medicine for veterinary patients is already here. But you know what? Actually, with all these subtypes and the personalisation in terms of the genomic changes, we still don't know fully how we should be interpreting that. And I can tell you now that we haven't got a different treatment and a different prognosis for each specific set of mutations or each specific disease. So for the individual case that's funded by the client or their insurance budget, this is not something that I would routinely be running to that extent. Also, if I've just diagnosed a dog with lymphoma, it's a bit of a drag to ask the owner to anaesthetise the dog and then take a lymph node out. Is there any more we can learn from cytology? I'll share with you my approach. If we stick to the 6 commonest types of multicentric lymphoma, we note that 3 are B-cell, okay? And with the high-grade and low-grade division, we can get further. If we know our lymphoma is B-cell and it's high-grade, then it's most probably this. Diffuse large B-cell is the commonest type of lymphoma in the dog. It's about 60% of cases. If we know our lymphoma is T-cell and of low grade, it's probably this, T-zone lymphoma, the commonest indolent lymphoma that we have. So actually you can narrow things down to 2 diseases, if not 1, with a combination of cytology and knowing whether it's T or B. And this is the way I tend to manage most of my lymphoma cases at the moment. In terms of getting the grade, well, actually the gold standard's histo, but a good clinical pathologist, especially one who's interested in lymphoma, will be able to give you a really good idea. They say, I'm 95% sure this is the grade based on cytology. How do we get the immunophenotype? Again, histology and immunohistochemistry is the gold standard. But actually, flow cytometry is also an extremely good test. If you look at the results here, flow cytometry, again it's answering the question, what cells are these? It will agree with immunohistochemistry in 94% of cases. It's of note that PAR falls down here. PAR has much less agreement, and again we've got this 67% sensitivity. It's going to get it wrong 1 time in 3. PAR is often offered by a lot of the labs because they can run it easily on the slide you've already sent them, but remember that it can miss things 1 case in 3. Now I'll tell you a little bit more about flow cytometry. We know it can give us the T cell, the B cell thing, and we know that the proportions of cells it comes up with can support a diagnosis of lymphoma or not. Actually, it can do more. And it's being evaluated all the time, and more uses are coming out for it. But we can pretty much nail a T-zone lymphoma diagnosis on flow. And actually, if pathologists are uncertain, they'll recommend running flow. We're also finding aberrant immunophenotypes. These are things that this is a term actually that didn't exist probably 15 years ago. Aberrant immunophenotypes are the cells where you have inappropriate expression of markers. There's no rules that govern a cancer cell. So if a T cell decides to express a few B cell markers, or decides to express no markers at all, or if you've got immature markers and mature markers on the same cell, or if you haven't got markers that should be shared with all white blood cells, we call these the aberrant immunophenotypes. It's quite an active area of research, but the first indications are that these guys will fare differently. In a case where you have cytopenias, there's always a bit of a question, is it actually a lymphoma or is it a leukemia? And that's more than just academic interest, because lymphomas typically respond very well to treatment, multicentric ones. Leukemias, very badly. Okay? And hitherto that was a clinical diagnosis, but now we have flow, we can look for this marker, CD34. If the cells have CD34, they have come from the bone marrow. They're a leukemia. If they don't have CD34, they've developed outside the bone marrow. They're a lymphoma. And lastly, flow is really, really useful when you're working up mediastinal masses. If you're wondering, is this mass thymic lymphoma, which is treated medically, or thymoma, which is treated surgically, it could be a very hard question to answer. If you try to sample a thymoma, you'll get loads of lymphocytes. That's because it's the organ where the lymphocytes mature. Okay? If you sample a lymphoma, you'll also, surprisingly, get loads and loads of lymphocytes. So before, it was actually a really hard call, and it meant a lot of lymphomas went to surgery unnecessarily. But if you FNA the mediastinal mass, send it for flow, we can look for this combination of markers here, CD4, CD8, and that is supportive of a thymoma. A lymphoma is just going to have one of these and negative for the other. And that is actually a very reliable test and frequently used now. So when you're talking about the subtyping of disease, then we should always think of histopathology and immunohistochemistry as the gold standard. It's the best established, the most tried and tested, and it still gives us the most holistic information. But in people now, techniques like flow and genomics are done additionally to the histopathology, and that's because they give different information and they help to consider things in a much more thorough way. So at the moment, in a lot of canine lymphomas, we can get the information we need to manage the case from knowing the grade and the immunophenotype, and other things like flow may give, for example, an aberrant immunophenotype, are very useful. But currently, in a lot of the lymphomas I'm managing, I'm not running histo just because we don't know what to do with the information at the moment. Moving on. So let's talk about staging of lymphoma now, and I think we're all aware of this. This is the WHO staging chart for lymphoma. Actually, in dogs, we tend to just get stage 3, 4 or 5. That's generalised lymphadenomegaly, plus minus liver or spleen, plus minus bone marrow or extranodal sites. So bear in mind, stage 5 can be something you get from just having lymphoma in an extranodal site, like the intestines or the eye. It doesn't have to involve the blood. If we want to stage a case of lymphoma, then this is a fairly good suggestion. Do CBC, biochemistry, urinalysis, image the chest, image the abdomen, take fine needle aspirates of the liver and spleen, because the liver and spleen can be deceiving. They can be infiltrated, if not effaced, with lymphoma and look perfectly normal. And lastly, do a bone marrow aspirate. But I can tell you now, staging is not going to give you reliable prognostic information, and it's hardly ever going to change the treatment that you give. On the note of prognosis, the earlier study suggested that stage 1 and 2 lymphomas, when they occur, do better than the others, and stage 5 lymphoma does worse than the others. But actually, the bigger studies, the better control studies and the more modern studies have shown no difference across the stages there. So based on what I've just said, there must be very little reason, you're thinking, to stage the dog. But actually we should consider staging in every case. If we don't stage a dog, we're not able to answer our owner's questions very accurately at all. We're not going to be able to answer our own questions accurately at all. For example, how do we know if the cancer is in remission? Often in a case of multicentric lymphoma, just the peripheral lymph nodes are the tip of the iceberg. There's often a lot of cancer cells in lymph nodes throughout the body, not least the liver and the spleen, and that's where, by mass, most of our cancerous cells are. And just measuring peripheral lymph nodes may not be an accurate representation of them. If we got a dog with a large burden of cancer as well, there's the theoretical possibility that he or she could become really unwell when you start treatment. It's the same reason a downer cow may die. A lot of cells dying at once will release a lot of things that should remain inside cells, for example potassium, phosphorus, nucleic acids, and these can cause renal failure. We call that tumolysis syndrome. Tumolysis syndrome is much more common in people than in dogs, and the reasons are quite complicated. But in dogs we do see a lot of inflammation just caused by cells dying, and they can be quite poorly. And this might govern your decision whether you hospitalise a dog or whether you send him home after starting treatment. A lot of dogs with lymphoma are middle-aged and upwards, and it's quite probable that they're going to have concurrent diseases. If your dog has clinical signs at diagnosis, and they don't go away after treatment, you'd kick yourself for not trying to find out what these clinical signs were due to in the first place. So knowledge of concurrent disease is very, very important here. And lastly, it's more pertinent in cats, but for some possibly extranodal or otherwise stage 1 lymphomas, you could consider local therapy, that's surgery or radiation therapy. It's not going to be too common that you do that in dogs, but if you've got one of those cases, you want to make damn sure there's no disease elsewhere. So I think it's okay to skip the staging, and you could skip it completely apart from bloods, and I'll be supportive of that, providing our owner accepts that we're not going to be able to manage the case, and we're not going to have our finger on the pulse as accurately as we would like. Now, to sum up my section on prognosis, the last thing is what's kind of intuitive to us. Those dogs who come in substage B, those who are very ill at diagnosis, they do worse. Those who come in bright-eyed, bushy-tailed, very excited, stage A, they tend to do better. And that's very important as well. And time again, the substage of lymphoma comes up prognostic in nearly every study. So, stage rarely affects prognosis, but it should be considered for monitoring and recognising concurrent disease. Now, it's high time we talk about treatment for our dogs. But before we do, the first thing we need to consider, if not briefly, is have we got a breed suitable for the MDR1 mutation testing? And we know about this as the mutation that makes collies very sensitive to ivermectin. It'll make the collies or other carriers of this mutation very, very sensitive to a lot of the chemotherapy drugs as well. So we want to know if this is present, really. Part of the problem with this, or an issue that we should understand really, is that when we think of a collie, we think of one of these guys, don't we? Border Collie. And actually in the Border Collie, fewer than 5% of them have the mutation. And bear in mind this test often costs £300 and takes a couple of weeks. When the Americans think of a collie, however, they think of one of these guys. Now the rough collie, this is a different kettle of fish, 70% prevalence. So we should, again, a bit like staging, we need to discuss this with the owners. If we've got a pastoral breed, like a Border Collie, a Rough Collie, do we do this test? And you've got to bear in mind the prevalence of it, the probability of having a mutation against the severity of not knowing about the mutation and just starting treatment. A couple of things I'd like to point out though is that the Australian Shepherd has a 50% prevalence, and these long-haired Whippet, Saluki type guys, again a 50% prevalence. And if you want to see a more up-to-date list on what the prevalence in different breeds are, then the Washington State University have a great website there for you to have a look at. Right, let's look at a case. This is Charlie, a 10-year-old poodle cross, and he has multicentric diffuse large B-cell lymphoma. This is the most common type of multicentric lymphoma in a dog. The average survival time with the standard of care treatments is about 14 or 15 months, but you could look at it another way in that half the dogs will be alive at 1 year and about a quarter at 2 years, and a very small percentage will be cured forever. Sadly, we can't predict who's who though. So we treated Charlie with the standard of care, the University of Madison, Wisconsin 19-week CHOP protocol. With this protocol you treat for 19 weeks, and actually they used to treat for up to 2 years. But in 2002 an important paper was published showing that those who were treated for 2 years did no better than those who were treated for the 19 weeks. So we stop after the 19 weeks, and we don't need to give any maintenance therapy. Charlie had 9 months remission, and then disease relapsed. So what would you like to treat him with now? Anyone got any suggestions? Have the CHOP protocol, what's your next go-to? Yeah. They're fair suggestions. Anyone suggest anything else? Do you know what we did? We gave him another CHOP protocol. And this is another important point, and it's not very well described in the textbooks. There are 2 reasons why a case of lymphoma can relapse. The first is drug resistance, and we know about that. But the second is just under treatment. We're very compassionate in veterinary medicine. The thing that limits the treatment we give is having a healthy, happy dog. And treatment of the disease falls second by a long way. So a lot of these guys relapse just because they've not been hit hard enough with the drugs. And we make no apology for that. I don't want to make dogs ill, and I'm quite happy to undertreat if it means dogs don't get ill. But this is an important point then. A lot of these lymphomas, particularly the diffuse large B cells, will relapse because they're undertreated, and the remedy is to start treatment again. Or, in practical terms, to give a test dose of vincristine, increase the steroids, and check what happens a week later. If things are looking good, then you continue just as you did before. Okay? So after the second CHOP protocol, we got a 14-month remission, and then relapsed. And at this point, I think the dog might have been suitable for more CHOP therapy. And I have had one Cocker Spaniel who relapsed about 12 times over the course of a few years, and for some reason he never got resistant to drugs. In the end we were treating him with like a COP protocol ongoing, and he lived to about 14. But in this case we got quite a real phenomenon that we will see, and that's owner fatigue. Our owner was unable to make the visits weekly again. Insurance funds were low. In fact, I think they'd been completely wiped out. And the owner also wanted a treatment that could be done more at home, with a home vet, less having to visit the referral centre and stuff like that. So out of owner's request, really, we started treating the dog with oral emustine every 3 weeks, and that got Charlie another 3 months, and then relapsed again and was put to sleep at that point. So overall, Charlie lived for 2 years, 4 months. And my key point here, and probably the most important point I'd like to bring up this evening, relapse in a dog does not have to mean rescue. In a lot of these cases you can look to reinduction, and they can do just as well, if not better, as they did the first time. If you get proper drug resistance, sure, you're looking at rescue therapies there, and the remissions are approximately half those seen initially, and with each relapse and each rescue the remission gets progressively shorter each time. I thought I'd include this as it's a question we're often asked. What about the COP protocol? Would that have done significantly differently to Charlie? And the answer is yes. Okay, the COP protocol and no rescue is this blue line here. That's the poorest survival here. The red line is the CHOP protocol. You can see it's obviously better than just the COP. What's interesting though is the cases that were treated with COP, relapsed and then rescued with doxorubicin, they're denoted by the green line here, and they had identical survival to a CHOP protocol alone. So this shows us then that we have some flexibility. It's not undermining a dog's prognosis in diffuse large B-cell lymphoma to treat them with a COP protocol, providing we're going to rescue them at a later point with doxorubicin. And that's still giving the same amount of drugs overall, but it's spreading it out, spreading out the intensity and the associated costs. There's a second interesting thing on this graph though. This purple line here is the dogs who received a CHOP induction and then were later re-induced with CHOP once again, and they did the best of them all. And in fact they did better than the yellow line, which was the CHOP cases that had a non-doxorubicin based reinduction or rescue protocol. And that kind of hints that doxorubicin is very, very important in this disease. And this graph distills it down further. So we can say categorically that doxorubicin is very, very beneficial for these diffuse large B-cell dogs. And in this study it was shown to be an independent prognostic indicator, surpassing all the other prognostic indicators. Look at Bertie now. Now Bertie was a multicentric peripheral T-cell lymphoma, and like a lot of the T-cell lymphomas was hypercalcemic at diagnosis. If a dog is hypercalcemic, he or she will become very unwell very early on in the disease process when the lymph nodes are tiny. So that can fool some people. In Bertie, we FNA'd normal size, normal feeling lymph nodes just out of procedure, and we got our diagnosis that way. Now, T-cell lymphomas don't respond as well as the B-cell lymphomas to doxorubicin. In fact, the response rate's in the order of about 50%. And so many oncologists, myself included, will elect not to use doxorubicin first line in these cases. It's an expensive drug, it has side effects on the heart, and something we don't realise, or often forget rather, is that it can be very toxic to the gastrointestinal tract as well, and that has a big impact on how our owner perceives the welfare of the dog. Instead, there's a strong feeling among the oncology community that these guys do better with a lot of alkylating agents like lomustine. So probably more than half the oncologists out there are treating the T-cell lymphomas with a lomustine based induction protocol, and that's what we used with Bertie. We used the PLOP protocol: procarbazine, lomustine, vincristine, pred. And one of the advantages of this is that a lot of it's given at home. It's one injection of vincristine every 3 weeks. Give the owner a load of tablets, see him again in a few weeks. So it's less intense on the visit side of things. T-cell lymphomas will never do as well as the diffuse large B-cell cases. If we treat these guys with a standard of care, the average survival is about 6 to 9 months. They'll respond just as nicely to chemotherapy initially, but they'll relapse quicker and they develop drug resistance a lot quicker, hence the much lower survival times. And this was the case for Bertie really. 2 weeks after the plop finished, he relapsed. We thought we'd try doxorubicin, see if he's in the 50% of dogs that will respond. We didn't. Then we started the DMAC protocol: dexamethasone, melphalan, actinomycin D, cytarabine. It's a good protocol. And he lasted about 10-11 weeks and then relapsed. We put him on a clinical trial, and the clinical trials really, for ethical reasons, have to be the dogs who have no hope. We don't know whether the trial drug will work. So we were considering him as a last attempt dog there, and the clinical trial got him 1 month, and overall he survived 10 months, and Sadly, that's about as good as a lot of the T-cell lymphomas do. We've got Susie here, golden retriever, and she had T lymphoblastic lymphoma. Now, lymphoblastic, as the name might suggest, in people is actually categorised as a leukemia that arises outside the bone marrow. And that can give you an indication for how well these guys do. This is a very, very aggressive disease, and the best survivals are in the order of 3 or 4 months, sadly. Now, Susie presented, like a lot of these guys, with more a mediastinal distribution of disease rather than peripheral lymph nodes. She had an accompanying pleural effusion, and when I met her she was in ICU at the RVC and she was oxygen dependent. I was called to have a look at her with an anaesthetist, and the guys were planning a TrueCut guided procedure to biopsy the mediastinal mass under GA. When I looked at the dog though, as is routine, I'm an oncologist, I examined her and I felt that the lymph nodes were bigger, the pre-scalp lymph nodes that is, were bigger than I was expecting. I stuck a needle in them because it's an easy and benign thing to do. I looked at the cytology in-house and we had a diagnosis 10 minutes later of lymphoma. We then scrapped the procedure to take the risk of anaesthetising the dyspneic dog and true cutting the mass. Now with this dog, she was an emergency case and we wanted to get her better as soon as possible. I can tell you now that most chemotherapy drugs work so slow that they're not suitable for emergency cases. So what we did here is we gave L-asparaginase, and this is a brilliant drug. We gave it along with steroids, which is also not a bad drug for emergency cases. The reason why these two are good for emergencies and nothing else really is because they work really, really fast. And so Susie rapidly left oxygen in the next 24 hours, and at 48 hours she went home. And that was great. We put her on the PLOP protocol, but then things weren't going so well. She relapsed during cycle 3, and then we tried a long list of things and we had no response, and ultimately she only lived for 3 months. This is a horrible disease. So my next point then, please always interrogate the lymph nodes in very sick dogs without a diagnosis. It's a cheap, easy, benign thing to do, and in both these T-cell lymphomas that's how we got our diagnosis. In an emergency situation like Susie, also consider the use of the fast drugs, that is the steroids and the L-aspar. Just quickly then, I've got another golden retriever here, Kirsten. She had T-zone lymphoma. And this is a good disease. You put them on chlorambucil and pred, just like a cat with low-grade lymphoma, and they'll often live for ages, at least 18 or 24 months on this treatment here. Be careful in the response you expect though, because it's a double-edged sword. Just as it's a slowly progressive disease, it will respond to treatment slowly. And often these lymph nodes never go away. But that's okay, providing that they're maintaining stable size, not growing again, and the dog's otherwise fine. Just a couple of things that are on the horizon. There is a drug licensed for treatment of lymphoma now in the States, and it won't be long before it's over here. It's been shown to be effective in induction in naive cases, alternating with doxorubicin, and the combination of these two gave the same survival as one-shot protocol. And it can also be used in rescue cases. So I'm not going to use it first line before it's better characterised, but it's a good tool to have in the toolbox in the rescue setting, and we can import that now with a special import certificate. The other thing is immunotherapy, and for years people have been trying to sort out an immunotherapy treatment for dogs with lymphoma. That's because rituximab is a monoclonal antibody used to treat people with B-cell lymphoma, and it has revolutionised the survival times for these people. So for a long time people have been trying to sort out an immunotherapy. It's very interesting, or I think so, but currently nothing has made it to success and to be sustained on the market so far. And so my last point now about treating dogs with lymphoma is possibly the most important one that I'm going to mention tonight. That is because most cases of lymphoma go wrong because of the monitoring going astray rather than anything else. Now, we want to monitor dogs with lymphoma really, really tightly, because when the disease starts to reoccur, those cells will be mutating. All cancer cells have very, very fragile genomes, and when they divide, they will mutate, full stop. And we don't want them to mutate, because when they divide, like a lymphoma divides, they'll mutate at an alarming rate of knots, and it's not long before the mutations will confer a survival advantage. For example, ability to cope and to move away from conditions of overcrowding. In other words, to metastasize, to spread further. Or they might start producing a protein that breaks down the drug, giving drug resistance. So basically, the more cancer cells we have, the more chance we have for the lymphoma to mutate and to become stronger and to become resistant. Now, based on clinical exam, I suggest we all make use of this document, which is in the public domain. It's produced by the Veterinary Cooperative Oncology Group, and it talks about maintaining 5 target lymph nodes, measuring their largest diameter and adding them all up, and we use that number as the sentinel of how we're doing on treatment. If we've got the percentages here for increase to call it progressive disease, or decrease to call it partial response. And also it states that if it's below 1.5 to 2 centimetres of all the targets, we'll call it complete response. And this is a great way to standardise treatment. But in a practice setting where different people are seeing the dog each week, I would make sure that it's the same people doing the measuring, because the measuring will always be subjective. Some people will squeeze the lymph nodes quite a lot to kind of flatten out the skin, the subcut fat. Others will be much more lenient. And that kind of variation individual to individual can really mess up the ultimate agreement on what's going on. But by clinical exam alone, that's not good enough. Clinical exam detecting remission of lymphoma is detecting the tip of the iceberg. The cells will be almost at the level they've ever been this way. So we should really be looking at techniques to pick up the lymphoma before we can see it. That is the minimum residual disease. And I'm going to suggest 3 methods now. The first is if your dog was hypercalcemic at diagnosis, then the ionised calcium is going to start rising 2 weeks before the lymph nodes are visibly large again. And that can be a very useful tip-off. The second is we could consider the canine lymphoma blood test marketed by Avacta, and that measures these 2 acute phase proteins here. If the dog had the high acute phase proteins at diagnosis, then they're going to start raising again about 5 to 8 weeks before the disease will actually recur. And that's quite useful, particularly in a situation where different people are reassessing the dog each time it comes in. My concern with this test is that C-reactive protein and haptoglobin, as we may know, are very non-specific. And if the dog has some inflammatory disease like bad ears, pancreatitis, osteoarthritis, that's going to generate inflammation in the body, and I dare say that these or other acute phase proteins can be elevated in those circumstances. So I guess this test may be useful, but it's also not so specific. The most exciting one then relies more on the PAR test. Now, actually, if you look hard enough in a dog with lymphoma, you will find lymphoma cells circulating. And that's pretty much all dogs. So in other words, most dogs with lymphoma are stage 5. And that's one of the problems the staging system has. So these guys had a very clever idea, and they thought, out of those dogs where they get a positive PAR test in the lymph node, can we find PAR positive results in the bloodstream? And yeah, they could. In 3/4 of dogs, the PAR positive lymph node is PAR positive in the blood as well. And these guys took that one step further. They adapted the PAR test to be quantitative, and they found that the levels of lymphoma in the blood were up here at diagnosis and went down here in remission, and then 4 weeks before relapse they're up there, 2 weeks before relapse up there, and at relapse they were up there. And this is an incredibly specific test for recurrence of lymphoma, and it can tell you how far off the recurrence is. So I understand that one of the commercial labs in the UK is looking to market this quite imminently, and when it comes online I'll be very excited to see it, and I think we should all consider using it to monitor these lymphoma cases. It takes away the person-to-person inaccuracy of just physical exams. Fine, so in summary for dogs, I'd recommend considering lymphoma as a differential for any lesion, and always please interrogate those lymph nodes in sick dogs if you haven't got a diagnosis. It'll cost you nothing. Please start looking at your own cytology. Look at one slide yourself, send the rest to the lab, and it won't be long before you're actually surprised by what you can see yourself. Consider finding out the disease subtype. That will help you choose an appropriate treatment and to give a prognosis to our owner. Bear in mind that staging is unlikely to give you a treatment or a prognosis, but is extremely useful for monitoring and for evaluating concurrent disease. Monitoring as accurately as possible is the key to success in managing lymphoma cases. And lastly, please remember that if deep disease relapses, it doesn't necessarily mean resistance. It doesn't necessarily mean that the prognosis has suddenly got worse. And I'll just leave you with this slide that summarises the 3 tests that I mentioned there and what they can bring to a case. I've only got a few slides about cats, so if we meet back, say, in 10 minutes, I'll go through the cats. It shouldn't take longer than about 15 minutes, I hope. So thank you all for paying attention. We're just going to have a quick look at cats now, and I'm going to highlight how they're different, really. Some of the biggest points are: cats tend to get extranodal lymphoma most commonly. Dogs, of course, typically get multicentric nodal lymphoma. Cats tend to be sick at diagnosis, and dogs tend to be the substage A healthy ones. The principles of diagnosing lymphoma in the cat are exactly the same as in a dog, except it's harder. Cytology is often harder to read. There's often a lot of ongoing inflammation there in the background, and it can be harder to get the wood from the trees. The PAR is less sensitive in cats than dogs for this reason, and flow cytometry currently is less well characterised. When you get to the treatment stage in cats, then their response to induction is usually poorer. They make a kind of 50 to 80% response rate versus dogs, which can be up to 95 in multicentric cases. And with cats, we don't tend to use the term reinduction at all. If disease relapses, it's usually drug resistant, and you're usually talking in the rescue setting there. Now, you can apply the WHO classification to cats just as you can dogs, and these are the 8 commonest types. Note 2 of these, intestinal T-cell and T-cell rich B-cell lymphoma, which have a better prognosis than the rest of the 6, which have a effectively identical prognosis. Now, in cats, there's greater interpathologist disagreement with this, and it's less well characterised in the first place. This study, for example, is only 30 cats. But the reason why I don't routinely ask for WHO classification in cats is because the only 2 with a better prognosis than all the others are very obvious clinically. One of them, the first one, intestinal T-cell lymphoma, well, this is what we'd call low-grade GI lymphoma in a cat, small cell lymphoma. It's a slow disease and often clinically indistinguishable from IBD. It tends to occur in older cats and has often developed from a bed of inflammation. They've often had IBD and often pancreatitis for many years before. And we should manage these. We should continue to manage things like B12 and flare-ups with gastroprotectants and things like that. And we treat them with chlorambucil and pred, and they usually do very well. With chlorambucil and pred alone, as I'm sure you guys all know, you'll get a disease-free interval of 18 months at least. And when disease starts coming back, you could use cyclophosphamide as a rescue. And when that doesn't work, you could use lomustine as a rescue. And when that doesn't work, you could use vinblastine or a COP protocol. And when that doesn't work, you could consider referring for radiation therapy. And I'll tell you more about that in a minute. But generally it tends to be a low-stress disease with a good outcome. The second type of feline lymphoma, which you may not have seen so much, is the Hodgkin-like lymphoma, T-cell rich B-cell lymphoma. This is characterised by huge lymph nodes, often just one or two of them, and often at the head and neck, in a cat who's otherwise fine. It's got a very unique histology. The cancer cells are these huge multinucleated B cells. Here they are. And these things are kicking out cytokines that attract lots of benign T cells, hence T-cell rich B-cell lymphoma. If you fine needle aspirate these lymph nodes, you will quite possibly miss all the cancer cells and get a load of benign T cells, and it will come back reactive. So diagnosis nearly always relies on histopathology for these guys. We don't know the best way to treat this yet. It's quite a rare thing, but we do know it does have quite favourable outcomes. There is one report of a case undergoing spontaneous regression. That's quite interesting. But a lot of the treatment to date has involved local resection or radiation therapy for the nodes. And when you locally resect them or you radiate them, they'll usually recur at some point later, kind of 6 to 12 months later, but the cat usually remains quite well. Now, I've been in the habit of treating these medically for the last few cases that I saw, again with chlorambucil and pred. And we still don't know whether that's right or not, but the reason is often when these things recur, they can recur distantly. And they may recur, say, in a mesenteric lymph node, and you may be in a situation where you've got huge mesenteric lymph nodes and you've only realised after that has occurred. So a lot of treatment has involved serial surgery, serial radiations, but because it can recur and it can recur distantly, my personal view is to treat them with chlorambucil and pred, and if the lymph nodes aren't big or causing a problem in the first place, don't even remove them. Interesting disease. But let's look at some of the more common high-grade lymphomas now, and I'm going to show you one of my favourite patients. This is Tootsie. Tootsie presented with a history of hyperexia, weight loss, and had mobile, painless abdominal masses, large kidneys, and was in poor body condition. On bloods we saw that she was azotemic, and when you bear in mind her poor body condition, this creatinine is artificially low. On ultrasound we found there was a mass at the ileocecocolic junction with destruction of the structure of the wall of the gut and obstruction of the lumen. There was a moderately large mesenteric lymph node, and there were large bright kidneys, and the right one I think had lifting of the capsule and a load of hypoechoic material between the kidney cortex and the capsule. This workup was done by the internal medicine team who I worked with at the time. They did cytology of the ileocecocolic mass, and that came back as hemorrhage, necrosis and inflammation. The lymph node came back as reactive, possible predominance of medium-sized lymphocytes. So in other words, it was non-diagnostic. What do you think we should do next? This is quite a real problem that you do encounter in practice. I've been there a number of times. Got a cat with abdominal masses, the cytology is not conclusive. What are you guys thinking?
Histo, aspirate the
Histo? And aspirate the kidney. Great, those are the two answers I was looking for. That's ideal. I can tell you what actually happened is the cat got sent to laparotomy for histo. But I think the guys working up the case at the time missed the trick here. And that is because cytology of a kidney is often a much more clear-cut situation than cytology of a lymph node. Under normal situations, you should not really have lymphocytes in a kidney. End of. In a lymph node, particularly a mesenteric lymph node, it will be full of lymphocytes, and there will always be some ongoing low-grade inflammation there. In other words, there'll be clones of lymphocytes there that will muddy the water and possibly obscure a neoplastic clone. So I think if we'd FNA'd the renal lesion, we'd probably get the diagnosis of lymphoma quite reliably. But as it was, this isn't the wrong way to take things, or the right way to take things. But a very understandable course of action followed. She went to surgery and the mass was resected, and the mesenteric lymph nodes were biopsied, as well as the perinephric tissue. That was biopsied as well. And it was a B-cell, high-grade lymphoma in all sites. So one more question then. Supposing that the cytology came back as supportive of lymphoma, would you have still gone to surgery? Or would you have treated medically? Have a show of hands for those who treat medically and those who go for surgery.
Depends if it was obstructive.
Absolutely. The key is in the answer here. Where is it? The word here. Obstruction of the lumen. Remember what I said for dogs? Most chemotherapy drugs just don't work fast enough. And in a cat who's getting cachexic and inappetent, taking 2 weeks for the obstruction to resolve, if it's going to resolve, because only 50 to 80% of cases respond, is far too long. So in obstructive cases, I think most people would agree taking to surgery is probably the most rapid way to solve the problem. So do we call Tootsie a renal lymphoma then, or a GI lymphoma? And we had lymphoma in both places. That's a bit annoying, isn't it? Do we look up the survival or treatment for renal, or do we look up that for GI? And well, I maintain it doesn't really matter, because if you look at the survival times here, they're all sadly lower than we'd like, but they're very similar. And there are reports from early on in the literature that renal lymphoma can be quite a different disease to other lymphomas in cats, and commonly occurs with CNS lymphoma. My personal experience is that that's not so common. I think most cases of lymphoma in the abdomen of a cat respond reasonably similarly and live similar times. So I might call Tootsie an abdominal lymphoma for the sake of argument, and that's an easier way I find to manage these cases. As we said, the survival time is not great. It's usually a few months. But I will say that in all feline high-grade lymphomas, there's 30% who live longer than a year. And so the range, the spread of survivals is absolutely huge. This is one of the larger studies of feline lymphoma. And if you look here, we're looking at the difference in survival of those treated with a COP protocol versus those treated with the Wisconsin-Madison CHOP protocol. There's actually no significant difference. So the type of treatment you employ doesn't really seem to have much bearing on the case. What does have a massive bearing on the case, however, is those who get a complete response to therapy where the disease can no longer be seen, versus those who just have a partial response to therapy where the lymph nodes just get a bit smaller. And that is the single prognostic factor in feline lymphoma. We don't talk about how ill they are, where the disease is found. We don't talk about the treatment we use. We talk about whether they respond to whatever treatment that is. And there's no other prognostic factor that stands up to scrutiny. So bearing that in mind then, the type of protocol we use doesn't seem to affect things. We need to choose a treatment for Tootsie. Bear in mind our cat is azotemic and has renal lymphoma. I don't really want to use doxorubicin, even if it was the right thing for her. That's because doxorubicin is nephrotoxic in cats. It's not the case in dogs. In dogs we tend to get cardiotoxicity or gastrointestinal effects. In cats it's the kidneys. Lomustine as well is a very big hitting drug for treatment of lymphoma per se. In dogs it's hepatotoxic. In cats again it's nephrotoxic. So you've got to bear in mind that the side effects in dogs really aren't transferable to cats. So what did we do in Tootsie? Well, we got the diagnosis a few days after her surgery, and she was still hospitalised. She was increasingly inappetent, and her azotemia had increased, and she looked really, really miserable. So I wanted to start chemotherapy as soon as I got the diagnosis. I didn't want to wait for a surgical wound to heal. And a problem that we have is chemotherapy is myelosuppressive. It slows down the division of cells. It's going to slow down cell healing. And for healing of a laparotomy wound, that's a problem. We don't want to suddenly find a cat with guts all over the kennels. So we used asparaginase. And just like I said, it's a useful drug in dogs because it's really, really quick. It's not myelosuppressive at all. And so both these things were useful in Tootsie's case. It worked quickly, and within a couple of days her creatinine was 160 and she was eating orally and doing much, much better. And because it's not myelosuppressive, we don't have to worry about interference with wound healing. And after we gave the L-asparaginase, we saw she made a good response to that, and we kind of incorporated it into a COP protocol. So we took the normal COP protocol and we added cytarabine and L-asparaginase. And why did we add cytarabine? And that's for the simple reason that it's another drug we can add. The average survival time for these guys is in the order of months. It's not very good. So we weren't happy to take the standard that gets the months. We wanted to do something to see if we get a better survival time. And why did we choose cytarabine to add? Well, it's not nephrotoxic, it's well tolerated, no cumulative toxicity. So about the phrase, above all, do no harm. So we gave 4 cycles of this complete empirical treatment like this. And then we scanned her and we found no evidence of disease, a complete response. And after that we gave her chlorambucil pred as maintenance therapy, just like a cat with a low-grade lymphomas. And she was put down last summer after being alive for 3 months and 3 years. So we were pleased with her. She went well. Shortly afterwards we saw a similar case, Cleo. And Cleo belonged to one of our colleagues. Cleo had lymphoma in the pancreas and a mesenteric lymph nodes and didn't seem to have much gut involvement or involvement elsewhere. And that again highlights that the term abdominal lymphoma is often easier than the many sites where it may be distributed. We treated Cleo in the same way. By week 8 she only had a partial response and she was showing signs of clinical regression. Partial responders we don't like. We want to do everything to maximise the chance of Cleo having a complete response. So we introduced lomustine. A fair thought, but in Cleo lomustine didn't do much apart from make her neutropenic for 4 weeks, and in a significant minority of cats that's what happens, they're neutropenic for ages. And after that then we introduced doxorubicin, and thankfully we got the complete response. So we gave another few cycles of doxorubicin, we scanned her to make sure she remained in complete response, and then we maintained her with chlorambucil and pred, and overall she lived 8 months. It's not brilliant, but it's certainly better than the average survival times. So point 11 then, response to treatment is the most important prognostic factor, and I would maintain it's the only prognostic factor we need to worry about. Choose a treatment that suits you and suits the cat and suits the owner. And if you're not getting a complete response, swap around the drugs to maximise the chance you do get a complete response. And keep rotating until you find the best treatment. When you've got the best treatment, you just continue for a little longer and then see what happens when you stop. I mentioned this earlier. Both Cleo and Tootsie, rightly or wrongly, didn't get rescue therapy when they finally relapsed. But radiation has to be mentioned because lymphoma is exquisitely sensitive to radiation, and cats are exquisitely resistant to the side effects of radiation. In this paper they were radiating cats' abdomens, and that sounds pretty harsh, doesn't it? It sounds like it would make them quite ill, but they had hardly any side effects at all. They had 2 small doses of radiation, one on day 1, one on day 2. And this drug-resistant group of cats that had failed all the medical therapies for both small cell or large cell lymphoma, went home in remission and lived for about another year without any more treatment. And this type of radiation therapy is not the most expensive or advanced treatment, and it's been done at the AHT and Southfields referrals, and it would be quite possible to organise that within the UK. So I thought I'd mention it.
Sorry, could I just ask, with the radiation therapy, would you, with that evidence in mind, would you personally look at it for first line treatment?
I possibly in some cases. It's not been very well evaluated in a large number of cats.
Right.
Notice in this study there's 11, and there's another study which looks at about 18.
Yeah.
And a statistician would say this is as good as no evidence at all.
Yeah.
So if we had a cat who was completely unhandleable,
Yeah.
and it was preferable to kind of do 2 quick GA procedures, GA in a crush cage,
Yeah.
and then bought a year of treatment free, you might consider that.
Yeah.
There might be practical considerations though. If you've got disease elsewhere, and something I'm going to come on to talk about in a minute, then the radiation of just the abdomen wouldn't cut it.
No.
The disease would recur. So you need to stage your cat very, very thoroughly.
Right.
There are some radiation oncologists that say if the bulk of lymphoma is above a certain size, then they're just not able to get that into remission with radiation. They'd have to use such large doses that you would get side effects. So there's technical things there. But what I will say is that particularly the guys at Southfields are very, very happy for you to discuss things like that with them. If you do have a psycho cat and you would consider this as a first line, then they'd be very happy to discuss it.
Thank you.
Let's look at Giza. And that brings me on to talk about Giza quite nicely. Now Giza had nasal lymphoma. You see it here. It's quite a common way it presents. Often you don't get nasal discharge, you just get distortion of the face with a mass bilaterally in the frontal sinuses. Sometimes people worry about diagnosing these because in a cat it's very difficult to have an implement that can go right up the nostril into the sinuses and grab a chunk of this. But actually most of these cases have thinning, or if not frank lysis of the frontal bones, if not in a small place, in a larger place. And if you've got CT, that's very easy to appreciate. If you haven't got CT, I would tape a marker to this, like an upturned drawing pin, and take a load of oblique x-rays, and you can see where the bit of lytic bone is compared to that drawing pin. You can then very carefully take a fine needle aspirate to that, and in a lot of cases you get a great diagnosis that way. Now, this is a high-grade lymphoma, but actually they do a lot better than the abdominal ones. Don't know exactly why. With a COP protocol, for instance, the median survival is about 2 years if they make a complete response, and still 4.5 months if they don't. This type of lymphoma could be called upper respiratory tract lymphoma, and you see rarer cases like lymphoma of the tongue, or lymphoma of the pharynx, or lymphoma of the larynx. And if you can get them over the acute airway obstruction in the first instance, then often they'll do just as well. A lot of these cases don't have disease disseminated throughout the body, so a more practical treatment, or more appropriate treatment if you like, you could consider radiation. With radiation therapy they typically do very, very well. But I will say, if you're going to send one of these guys for radiation, you need to make damn sure that there's not disease elsewhere. And in the case of primary nasocyanal lymphoma, about 20% of cases will also have involvement of somewhere in the abdomen, usually kidneys. That's often silent, often the creatinine's normal, but the disease is elsewhere. So to be safer, you could treat the cat with chemo. But if you're willing to stage the cat thoroughly and the owner's willing to travel for RT, radiation's also a great treatment for these guys. So, remember this cat, Ryan, I showed you at diagnosis. And he had a detached retina. Normally in a detached retina, due to hypertension, you will see large tortuous blood vessels, and you may see bleeds, and often you'll see a lot of blood, if anything, at the back there. But what we saw here was very, very thin blood vessels, and the whole retina looked thickened and less reflective. And you can see it on CT. We've got the lymphoma infiltrating the retina compared to this one. And going further, the lymphoma is actually infiltrating the optic nerve. You can see all this fuzziness here, which you haven't got on this side there. So how do you think we can get the diagnosis in cases like this, or cases with neurological signs? Because I'll tell you now, I'm not in the business of FNA in retinas. Well, actually, it's the same way, staging. Just on the same principle that a lot of these cases will have disease elsewhere. And in Ryan, we found a little nodule on one of his kidneys, we aspirated it, and we got the diagnosis very, very safely, enabling him to keep the eye. Once we started treatment, the retina reattached within about 5 days. So again, for cats, you're more likely to be thinking of local therapies like surgery, like radiation, and staging is essential if you're considering one of these guys. Staging can also help you find a diagnostic lesion. But as for dogs, the prognostic value is very limited, and often it doesn't change the treatments that you give. So Muro is my last case today. And Muro was regarded by the feline-friendly nurses at the RVC as a bit of a character. There were actually other terms in use quite commonly, but I'm not going to repeat those now.
So he could send for radiation then?
I'd love to. It would send him elsewhere in general. I think I'd be fully for it. But no, Muro had a kind of mediastinal lymphoma. And this was a bit weird. Mediastinal lymphoma is scary because it smacks of FELV positivity. Typically in young cats, they have big mediastinal mass and typically they do very poorly. We're in the post-FELV era now, so we don't see a lot of this, and actually Muro was negative by PCR for FELV, both in the bone marrow and the blood, so he's not an FELV cat. But he had a big mediastinal mass and it was making him dyspneic. Muro, despite being a challenge, and he was a 4-nurse cat, if you understand what that means. You measure the difficulty by the number of nurses that it takes. He was a very well-loved pet, and his saving grace was that the nice lady who owned him was able to give him oral medication. So with Muro then we went a bit off-piste, and we gave him L-asparaginase subcuts to try to knock down the disease as quickly as we can. And then, second day, the lady would give him lomustine orally at home. And lomustine is a slow-burning drug. If you use that on its own, you're unlikely to get the disease into remission. So it works well with L-asparaginase, which is a quick knockdown, and then the effect wears off. And we did that in 3-week rotations, and he lived for about 6 months, which is a good compromise, particularly since his quality of life wasn't too affected. Now, I've never used this, but I thought it's worth mentioning because my colleagues at Liverpool really like this. And this is their way of dealing with the hands-off cats. Week 1, lomustine orally. Week 3, procarbazine orally and cytarabine subcut. And then week 5, week 1 again. And it rotates on a 5-week cycle. Now, I was surprised this works because lomustine and procarb are similar. They're slow burners. There's nothing that provides a quick knockdown to the disease burden there. And also cytarabine, given subcut, has been shown not to be very effective for control of cancers. And the reason is it acts at a very, very specific point in the cell cycle, and so if you give it as a bolus, it'll kill a few cells and no more. If you give it as a CRI, it will kill all the cells as they come into that point in the cell cycle, and overall the tumour control will be much greater. So cytarabine should really be given as a CRI for the treatment of lymphoma. But I'm not going to knock it, because there's a great bunch of people at Liverpool and they say it works really well. So we could also try this. And my other suggestion for the difficult cats would be just sedate them every 3 weeks and give doxorubicin. I think that's a bit better for dogs because doxorubicin works better in dogs than it does cats. The response rate to doxorubicin on its own in a cat is actually less than 30%. So that's why I've put this one at the bottom of my suggestions. Finally, have you heard of these? Vascular access ports? They're quite good to think about. They're particularly good for the cats or dogs with really, really bad veins. And this sterile cannula is designed to be permanently implanted in either the femoral vein or the jugular vein. And this bulb here would permanently sit subcutaneously just behind the scapula or just in front of the point of the hip. And it turns a blood sample or an intravenous injection into a subcut injection. The point I'd like to make though is that these aren't so clever for the aggressive dogs or the difficult cats. That is because you need to sterilely prepare the surface where you inject for a long time, just as you're going to do a bitch spay. It's very, very easy to introduce infection into these. Once you've got the needle in place there, it kind of locks in place, and it's designed so you take the blood, you go and run the blood, and you've still got the device sticking through the skin, and then you give the chemo 20 minutes, 30 minutes afterwards. And when the needle goes through the skin, even if you've put, what's that numbing agent? Emla. If you put Emla cream on the skin, or you've used anything else like Ethicalm, they still feel it. So I would consider these for the bad vein cases. I wouldn't consider these for the difficult animals. It's my personal view. So in summary, most cats have extranodal lymphoma and are sick. The response rates to treatment are lower, and although extended survival is possible for about a third of the high-grade cases, in general, when the disease recurs, it is often quite bad. You're in a rescue setting, a disease-resistant setting. Histopathological disease subtype, flow cytometry are less well established, and you go into just routine histo where the cytology is equivocal. Local therapy is more likely to be possible in cats and dogs and should be considered for certain cases, but you need to stage them thoroughly. And when you start treatment, remember that response to treatment, complete remission versus partial remission, is the best prognostic indicator we have. If we've only got a partial remission, we should rotate those drugs round to maximise those chances of getting complete remission. And beware that side effects are different, particularly care with the kidneys. So that summarises everything I was going to say today. Thank you all for being such a good audience and very patient and staying awake. If you've got any questions or you'd like to discuss any cases, I'll be more than happy to do so.
Thank you.